AETCM, the emergency medicine channel. Shall I start?
Yes.
Presenting the case of a 56-year-old male who came to ER with complaints of multiple episodes of loose stools since one day, along with crampy spasmodic movement of bilateral wrist joint and hand since last 4 hours. On initial 10-second assessment, the patient was conscious oriented. He was talking in full complete sentences. The airway was patent. There was no pooling of secretions or gurgling sounds or stridor. And the breathing wise, the saturation was 96% in room air. And on auscultation, there was presence of bilateral basal repetitions was present. A respiratory rate of 20 per minute. And circulation, the BP was...
Age of the patient?
56 years. And circulation wise, the BP was 126/66 millimeters of mercury with a pulse rate of 80 per minute and a capillary refill time of less than 3 seconds. And disability wise, the GCS was E4, V5, M6. Pupils were equal and reactive to light of size 2 mm. And exposure wise, the temperature was febrile. GRBS was 101. And there was no presence of any external rashes in this patient. And as part of adjuncts to the primary survey, we had taken a CBCRP point of care was taken for this patient, showing a total count of 7,800 with an HB of 9.6 and a platelet count of 1,66,000 and a CRP of 0.2. We had also taken a venous blood gas for this patient, showing no acidosis or alkalosis with HB of 9.8, potassium of 3.8, and calcium was found to be, ionic calcium was found to be 3.3. So it was found to be low. And along with that, creatinine was 1.3, lactate of 2.1, sodium was 136, bicarb was 23, the anion gap of 7. Following which, we had also taken an ECG. So in ECG, there was presence of T inversions, new changes as in V1 to V4, with the QT was slightly prolonged. It was 470 millisecond.
470.
Yeah.
44 to 450 is a normal
range. So it was slightly prolonged. And we have also done a troponin. We have done a point of care troponin also, which was negative. Following which, we had taken a sample history too. The sample history patient was a 56-year-old male. He was a known case of type 2 diabetes. He had a history of ACS STEMI in 2023, following which he developed a heart failure with preserved ejection fraction. And he came to ER with...
What are the two important types of heart failures, you know? One you told just now.
Yeah. Heart failure with preserved ejection fraction.
Reduced
ejection fraction.
What is this preserved ejection fraction?
In such individuals, the ejection fraction will be more than 50%.
So that means what? Where is the failure?
LV? Diastolic.
The commonest thing is diastolic dysfunction. It can be due to diabetes, hypothyroidism, or so many other conditions. Okay. So there are conditions where the ejection fraction is high, like anemia, beriberi, thyrotoxicosis. That is also a type of heart failure. That is, ejection fraction is very high.
So
in this type of patients, when they come to ER, what precaution you have to take? So why we are worried about heart failure with preserved ejection fraction? It is not like other condition where we know everything, we avoid some things. Here, what is the problem?
Extensive fluids.
Here also the problem is excess fluid can very fast the patient can go to pulmonary edema. Okay. Heart will not receive that much fluid. So the fluid can accumulate in the pulmonary circulation. So we have to be very careful. Okay.
So this patient had come to ER with complaints of multiple episodes of loose stools. It was more than 8 times gone to the patient since one day. Along with the patient had developed a spastic movement of the bilateral wrist with hands. It was involuntary movement since the last 4 hours. Following no history of any fever, vomiting or any abdominal pain, headache or breathing difficulty for this patient. No history of any chest pain or palpitations for this patient. No history of any, and patient gives a history of generalized tiredness since last one day. No history of any seizures or confusion for this patient. No history of any memory loss or no history of any circumoral paresthesia was not present in this patient. No history of any dry skin or no history of any increased pigmentation of any body
only
part.
Thing is movement of the hand with low calcium.
Low calcium.
How do you confirm that this is because of hypocalcemia, or it can be due to some abnormal movements due to neurological disorder? How do you know that it is hypocalcemic change?
Hypocalcemic changes, we can check the serum calcium levels.
That you already told
Can
it.
be done.
Two
What
tests
test?
can be Schwartz test.
What is the test you do on the hand?
And we do Trossius.
What is it?
We attach the BP cuff. BP cuff.
Slightly increase the BP and keep for some time. You can visibly see that
Pedals.
carpal spasm. Pedal means yeah.
So the carpal spasm can be identified when we try the BP cuff. Next one is the Shostak sign. So Shostak sign, usually there will be presence of a twitching movement.
Okay,
facial twitching movement when we stimulate the facial nerve.
Okay.
So these are the two signs which we do. But these are not specific.
Okay.
For
What is the respiratory rate in this patient?
This patient had respiratory rate of 20.
20.
Yeah.
What is the carbon dioxide CO2 level?
So we had taken a venous blood gas, but in that showed 29.
29.
Yeah.
What is the pH of this patient?
pH was 7.41.
7.41. Is it all important?
Yes. And
Why
because
it
of
is important?
patient, if the patient has a respiratory alkalosis, they will have the presence of reduced ionic calcium. So that can present with perioral numbness, and also patient can present carpal spasm. So as in patients with increased anxiety, individuals when they present with anxiety attacks, they can also get similar issues. And following which, this patient baseline has a dyspnea on exertion, grade 2. No history of any increase in grade of dyspnea for this patient, or no history of any chest pain, palpitation. No history of any trauma to the limbs, or no history of any infection also. No history of any fever for this patient. Allergic history, the patient was not allergic to any medications. Medication history, the patient is on metoprolol XL and 50 mg and BD dose, and the patient was on Lasix 40 mg BD dose, and patient was also on metformin 500 BD dose, and glimepiride 1 mg was taken as OD morning dose. Past history, the patient has history of an ACS STEMI 2023, followed by the patient has developed a heart failure with preserved ejection fraction, and the non-case of type 2 diabetes. Last meal was taken 2 hours back. We had done the labs. The patient had a total calcium of 5 milligram per deciliter. So patient
Normal being 10.
Normally being 8.5 to 10.
8.5
to 10. So this patient had a lower calcium limit. Along with that, albumin was 3.6. So we checked the corrected calcium also. Corrected calcium is the formula is the total calcium plus 0.8 into the normal albumin level minus the serum albumin level. So in this individual, we take the normal albumin level as 4. So it is 5 plus 0.8 into 4 minus 3.6. So it was 0.4. So it was 5.32 was the corrected calcium for this individual. Still, it was on the very lower side. And for this patient, we are also done the pancreatic amylase lipase also, and LFTs also was done.
What will happen in patients who is having pancreatitis?
In pancreatitis, there will be increased bile salts will be used. The calcium will be increased used up. So hypocalcemia can be present.
Hypercalcemia can produce pancreatitis.
Yes, hypercalcemia is a cause of
that is also there.
Cause of pancreatitis. So that markers turned to be normal. So we came to a provisional diagnosis that a patient developed hypocalcemia due to gastrointestinal loss, GI loss, along with usage of Lasix. Okay. So that could be.
If you don't treat this patient, what will happen?
The patient has already developed ECG changes, so the patient can move into ventricular arrhythmias.
That is one. Second thing, as a ER physician, what is more bothering you?
Laryngospasm.
This patient may go to respiratory arrest anytime because of laryngeal spasm. So both are important. ECG arrhythmias can happen because QT is already prolonged. The other one is patient can develop laryngospasm, then he'll have difficulty in intubating the patient. All sorts of problems can happen there. Okay.
Following, we also checked the phosphorus level. Phosphorus was 3.
Normal.
Following which we had for this individual, we had given mainly the medications of like anti-gastrointestinal medications.
How do you correct this calcium?
Yeah, in this patient already was showing symptoms of hypocalcemia. So management of hypocalcemia mainly involves if patient is symptomatic or asymptomatic. So if this patient already had a symptoms of hypocalcemia with a very low calcium. If patient's total calcium level is less than 6 milligram per deciliter, the patients can usually present with ECG changes too.
Okay.
So in such individuals, we must give IV correction. In this individual, we had given 10% calcium gluconate, 10 ml over 10 minutes we had given. We can give up to 30 ml can be given.
Calcium gluconate.
Calcium gluconate can be given. Another alternative is calcium chloride.
What is the difference?
Calcium chloride is 3 times more potent than calcium.
So where will you use calcium chloride? Where will you use calcium gluconate?
Yeah. Calcium chloride is usually given in case of massive transfusions.
So correction. When you want to correct, calcium chloride is better choice.
Yes.
When you treating with arrhythmia, for arrhythmias like hyperkalemia, all these things, calcium gluconate is better. Not better, it is safer.
The side effects mainly involves vasoconstriction. So there can be a possibility of an ischemic event also in such individuals. So it must always
So
be
fast correction, we can give calcium gluconate. Slow correction over time, we have deficiency. Then calcium chloride will be a better choice. But we don't have this calcium chloride. So how did you correct this patient?
This patient we had given IV calcium gluconate 10%, 10 ml over 10 minutes, following which we had sent the repeat calcium level, which was turned to be 6.5.
Ideally, you have to start infusion in this patient, not bolus doses. After initial bolus doses, you have to continuously infuse this patient till it is getting corrected.
Following which the ECG changes had the teen versions in V1 to V4 had reverted following the changes, and QTC had also reduced. Following which the patient was admitted and observed. And
what other investigation you do for this patient other than what you have sent? You have sent some basic investigation, ABG, so many things you have done in ER, ECG, acute problems. How do you go ahead with that investigation?
We can do PTH, parathyroid levels.
So you can get parathyroid hormone low with hypocalcemia, parathyroid hormone high with hypocalcemia. So what are these conditions? Suppose your parathyroid hormone is destroyed due to autoimmune disease, infection, what will happen to PTH? PTH will be low, calcium will be low. Suppose calcium is low because of vitamin D deficiency, what will happen to PTH?
It is increasing.
So both the conditions you can get high, either low or high PTH. So depending on that, you have to diagnose. So we have to send a vitamin D level. What is the vitamin D level?
This patient is found to be in the lower side.
Lower side. So that also has to be corrected. What is PTH?
Parathyroid hormone. Usually it upregulates. Usually it helps.
And this patient, have we sent it or not?
Yeah, this patient we had sent.
Is it available?
No, it is not available.
So ideally you have to follow up. If vitamin D is low, PTH is high, it's a secondary hyperparathyroidism. You have to correct the vitamin D also along with this. Okay. Magnesium also should be checked.
Yeah, in this patient magnesium was 2.
That is normal. Both hypo and hyper should be ruled out.
So as part of hypocalcemia, hypocalcemia is usually defined as an ionic calcium which is less than 2 milliequivalents per liter. So that is a usual definition. And usually
here it is 3.
The ionic calcium is 3. But the total calcium was less than 8.5. And usually the various causes of hypocalcemia mainly includes the different drugs. So mainly the drugs which cause hypocalcemia includes phosphates. So usually in case of enemas or laxatives.
Any diarrhea or diarrheagenic drugs can produce.
And increased GI loss or phenytoin or phosphonatoin, phenobarbital. Then antibiotics like gentamicin, tobramycin, and even foscarnet. Cisplatin and anti-cancer drugs can also cause, along with loop diuretics. So this patient was on furosemide. So could be one of the causes which cause hypocalcemia. And patient usage of glucocorticoids and magnesium sulfate.
What glucocorticoid will do to calcium? What it will do? So very commonly we are using this drug now in asthma. ARD. So many conditions we are using. Chronically, we are using for rheumatoid arthritis, SLE. Calcium? What will happen to the calcium if you are taking glucocorticoid? So one of the treatment of hypercalcemia also.
Yeah.
So why? What will happen? It will cause hypocalcemia. How? If you know how, then it is easy. Because it prevents the absorption of calcium from the intestine. Okay. So that you should know.
Or calcitonin or usage of calcitonin or denosumab, as in osteoporosis. Such drugs also can cause hypocalcemia. Usually the symptoms of hypocalcemia can be classified into various categories. The first one is muscular. Muscular mainly involves muscular weakness or fatigue and spasm or cramps, the involuntary movements.
Neuromuscular irritability. That is the main thing.
Yes. Along with that, the patient can develop neurological manifestations like seizure or tetany. Tetany is a carpopullar spasm, involuntary carpopullar spasm can be seen. We can also see circumoral or digital paresthesias in the numbness can be identified. Our patient can develop memory disturbances, confusion, dementia, delirium. And extrapyramidal symptoms like dystonias can also develop in such individuals. Along with that, dermatological manifestations mainly involves hyperpigmentation. So hyperpigmentation is one of the manifestations. Along with that, dry skin and brittle hair. And cardiovascular mainly involves heart failure. So it can precipitate heart failure. And also ventricular arrhythmias, QT prolongation, and can mainly lead to even non-specific TV inverse STT changes also. Along with vasoconstriction. The patient uses skeletal manifestations includes rickets and osteodystrophy, and the miscellaneous other manifestations includes cataracts. So always we should rule out like blurring of vision.
Acutely abdominal pain is one of the main clinical findings.
So the diagnosis is mainly with total calcium along with the ionic calcium levels. So ionic calcium levels less than 2, we diagnose it as hypocalcemia, and total calcium less than 8.5. And if total calcium is less than 6, ECG changes is more likely to manifest. And the treatment mainly involves if patient is asymptomatic. If the patient is asymptomatic and if hypocalcemia is not severe or it's prolonged for more than 10 days to 14 days, we can even start with oral therapy. So oral therapy of calcium mainly involves calcium lactate. It's a tablet used, or we can use calcium carbonate or gluconate tablets also are available. And usually we give it at 500 to 3000 mg elemental calcium in a daily dose. It's usually in one dose or can be given in up to 3 divided doses. So this is usually in case of asymptomatic individuals. If patient is symptomatic, we should go with IV correction. So in IV correction mainly involves the IV calcium gluconate is more preferred than IV calcium chloride, because if we are giving IV calcium chloride, there can be increased chances of this calcinosis cutis, presence of calcification along the skin, fingers and also. So that can occur. Along with that, if the patient is having severe acute hypocalcemia, the agent of choice is calcium gluconate. It is 10 ml of 10% calcium gluconate can be given, and which is given over 10 minutes, and can be given up to 3 doses. And the continuous IV infusion can be given at a dose of 0.02 to 0.06 ml per kg per hour. So that is the dose of correction. And so these are and during massive transfusion, we must always give calcium chloride as a supplement.
Okay. This patient may require calcium chloride, but we don't have calcium chloride. That's why we select calcium gluconate on it.
Yes.
Okay. Anything else? I think.